Dear ladies and gentlemen, thank you for giving me the opportunity to talk about HPHMG, to talk about the abbreviated scientific saga, as it is called. So I would like to express my gratitude also to the people of Ferring from Poland to give this opportunity. And indeed, it is a special year for Ferring, as you might know, because actually this year, 20 years ago, HPHMG came to the market. And up until today, there is quite some body of evidence available with regard to HPHMG. So let us maybe start to have a look at all these different published studies. And we start with the EISG randomized control trial. That was actually the first randomized trial comparing HPHMG with recombinant FSH in IVF and ICSI patients. It was a study that included 780 patients of normal age between 18 and 38 years old. And the primary outcome measure was, like we will always have in the next coming studies, was the ongoing pregnancy rate. So let us have a look at this study in a long agonist protocol where HPHMG or recombinant FSH was given in a dose of 225 units. Adjustment was allowed after 5 consecutive days of 225 units. And then the trigger was given, and 1 to 3 embryos at that time, 1 to 3 embryos were replaced into the uterus. The results were quite convincing that there was no significant difference between HPHMG versus recombinant FSH at the level of ongoing pregnancies. So we were quite happy with this first result in 2002. When Peter Plateau looked into the data more in a detailed way, he said, well, did you look at the results, at the IVF results on one hand, and at the ICSI results on the other hand? Because in the IVF group, when comparing HPHMG versus recombinant FSH, the HPHMG group performed much better. And of course, there have been a lot of speculations why HPHMG performed better in the IVF. Was it because of the HCG in the cumulus cells? Was it because we have more experience with IVF as compared with ICSI at that time? We don't really know. But actually, the design of the next study was based on IVF patients alone. And this was the so-called MERIT study. You remember the MERIT study? It was the large RCT in a GnRH agonist long protocol, phase 3 study in 37 centers, 730 patients included, to compare FSH and HPHMG. And again, the primary endpoint was the ongoing pregnancy rate at 10 or 11 weeks of gestation. So yes, again, the dose of 225 units of recombinant FSH or HPHMG was given, and adjustment was allowed after 6 consecutive days of stimulation. So then only IVF was performed, and looking at the primary endpoint, it was quite similar as we had with the EISG study, namely a non-significant difference of 5% in favor of HPHMG. When looking at some secondary outcome measures, it was interesting to see, and this is coming back all the time, that with HPHMG, we will have significantly less oocytes. But on the other hand, although we had significantly less oocytes at the time of oocyte retrieval, there was a non-significant, or even here, a significant higher number of top quality embryos on day 3 of embryonic development. So this is interesting to see. For less oocytes, an equal or even more number of top quality embryos. On the other hand, in terms of live birth rates, in terms of early pregnancy losses, there was no difference between HPHMG versus recombinant FSH alpha. Safety was an important measure in the MERIT trial conducted at that time. We are talking about 2006. And as you can see, there was no difference in adverse events between the two compounds. When looking at the data, it was actually Johan Smits in 2007, and then later published by Arce and Smits, who said, well, actually, when we measure HCG and LH on day 6 of the ovarian stimulation, it is not the LH that plays a role. With increasing levels of LH, you don't see any improvement. But looking at HCG, so the HCG-driven LH activity that is present in HPHMG, with increasing levels of HCG, you can also see increasing live birth rates. So this makes it so interesting to see the impact of HCG or HCG-driven LH activity on the end of the day. Let us move to the GnRH antagonist protocols then, because Ernesto in 2008, so Ernesto Bosch from IVI Valencia was actually the first colleague who did a randomized study with HPHMG versus recombinant FSH in a GnRH antagonist protocol. And actually in this study encompassing around 280 patients, if I'm not mistaken, there was no difference in outcomes, implantation rates, ongoing pregnancy rates, pregnancy losses, no difference at the end of the day. The large megaset RCT, you remember the large RCT comparing HPHMG versus recombinant FSH in an antagonist protocol published by my scientific father, Paul de Vroey, was a straightforward study, RCT. Again, 750 patients included in this study with the primary outcome of ongoing pregnancy rate. And at that time, you know, we are later in the evolution, we are decreasing our FSH dose. So in both arms of the study, the starting dose was 150 international units, both in HPHMG and in recombinant FSH. After 6 days of stimulation, there was an adjustment allowed to increase or to decrease the dose. Also innovative was that the primary endpoint was the transfer of one single blastocyst on day 5 of the embryonic development, and then micronized vaginal progesterone was foreseen as luteal phase support. So again, the ongoing pregnancy rate was the primary endpoint of the study. And again, there was a non-significant higher pregnancy rate in the HPHMG arm versus recombinant FSH. So very nice data to make the body of evidence stronger, comparing HPHMG versus recombinant FSH. Looking at the frozen embryo transfers of the megaset HR, again, no difference in terms of ongoing pregnancy or live birth rates. So that was also interesting. And then finally, when we look at a post hoc analysis that was made in high responder patients or expected high responders with an AMH level of more than 5 nanogram per ml, so a small subset of 150 patients of this study showed that live birth rates were significantly higher in HbHMG. Of course, we are talking about a post hoc analysis. This is not an RCT, but when we look at live birth rates that are higher in HbHMG, when we look into safety, and namely lower rates of OHSS in HbHMG, actually people started to think, and this, of course, was the design of the recently published Megaset HR study. So when we look at patients with high AMH, always the same findings: lower number of oocytes with HbHMG, lower rates of OHSS with HbHMG, and higher live birth rates per embryo transfer with HbHMG. So this is how we came to the Megaset HR, a study that was conducted in the United States, published a couple of months ago in Fertility and Sterility, antagonist cycles, high responders, and single embryo transfer. So when we look at the inclusion and exclusion criteria, so patients were allowed to enter the study if the AMH was above 5 nanogram per ml with normal testosterone. So we are not talking about the hyperandrogenic PCOS patients. No, we are talking about high responders, high AMH with normal testosterone. Of course, the exclusion criteria were the classical exclusions of endometriosis, grade 3, grade 4. We had, of course, as an exclusion, repeated implantation failure or recurrent miscarriage. And then there was a transfer at the blastocyst stage of one single embryo. So people in the United States, actually in 30 or in more than 30 centers, 620 patients were randomized into HbHMG versus recombinant FSH with 150 units. An adjustment was allowed from day 6 of the stimulation onwards, and then patients were triggered as soon as 3 follicles of 17 millimeters were observed with recombinant HCG. But please have a look at the red bar. Only an agonist to trigger was foreseen when 30 follicles of 12 millimeters and more were observed. So can you imagine? We are in the United States. There, they don't use the 18 or 19 follicles of 11 millimeters or more, like published evidence, but they say, let's shoot at 30 follicles of 12 millimeters and more only. The agonist was given and a freeze-all strategy was applied. So the primary endpoint, again, like all the other studies comparing FSH with HbHMG, was the ongoing pregnancy rate per started cycle with the presence of one or more than one intrauterine pregnancy with a fetal heartbeat at 10, 11 weeks of gestation. Further on, I will draw your attention to some very interesting secondary endpoints, such as live birth rates, OHSS rates, which you can already imagine, the clinical pregnancy rates, but especially the early pregnancy losses. And even more interesting, patients were followed up even 6 months from the randomization. So the consecutive frozen embryo transfers were also studied and taken into account. So let us have a look at the patient disposition. So 620 patients were randomized in 31 clinics in the US. So 310 in each arm of the study. And you can already see here on the left that patients triggered with a GnRH agonist, 37 in HbHMG, and significantly more, so 54 in the recombinant FSH arm. So interesting finding already there. Let us have a look at the baseline characteristics of the study. So patients of younger age, 30 years in as a mean, normal BMI, normal FSH, and extremely high levels of AMH, 7.5 and 7.8 nanogram per ml, so extremely high responders included in the study with antral follicle counts of 30 and 31. Reasons or indications for infertility were similar in both arms of the study. So let us have a look at the stimulation characteristics. Patients who were prescribed HPHMG had a longer stimulation, 1.5 days longer. So the consumption of FSH was higher, 2,000 units compared to 1,500 units in recombinant FSH. But please have a look at the number of oocytes. 15 oocytes were retrieved in the HPHMG arm versus 22 oocytes, 7 oocytes more in recombinant FSH arm. We will look more into detail. So let us have a look at the endocrine profile. So patients started, of course, in basal circumstances. So we are talking about picomole, so on 137, 144 picomole per liter, E2. And then we observe higher levels of E2 in the recombinant FSH arm on day 6 and at the end of the stimulation. So significantly higher in the recombinant FSH arm. But this was the primary endpoint, ongoing pregnancy rates. And that was, although 5% higher in HPHMG, it was not significantly different. So similar findings of ongoing pregnancy rates in both arms. Similar findings of live birth rates per transfer in both arms. But please, can I draw your attention to the early pregnancy loss? Because as you can see, there was close to 10% lower early pregnancy losses in HPHMG versus recombinant FSH. And I know it is a secondary outcome measure. I know that the study was not powered to prove any differences in miscarriage rates, but isn't this striking? Close to 10% less miscarriages in HPHMG. We start with 7 oocytes less in HPHMG versus recombinant FSH. But the further we go, mature oocytes, 2PN oocytes, the number of blastocysts on day 5, and the number of top quality blastocysts on day 5, you see that the difference is decreasing, and is getting non-significant when talking about excellent blastocysts on day 5 of the embryonic development. But these are cumulative figures. These are taking the frozen embryo transfers into account. And again, we see a non-significant higher live birth rate in the frozen transfers as compared with recombinant FSH. But again, look at the early pregnancy loss. Talking about the frozen or talking about fresh plus frozen, you see a lower early pregnancy loss in the HPHMG arm. And of course, you can say that the difference is probably at the level of the endometrium in the fresh cycles. But when we observe lower miscarriage rates in the frozen embryo transfer cycles, then maybe we should think